Good morning. My name is John Procaccino, and I am the Chief of Colon and Rectal Surgery at North Shore University Hospital. March is Colon Cancer Awareness Month, and with that in mind, I'd like to talk to you today about a very significant topic, that is colorectal cancer. So the title of my talk is Everything You Wanted to Know About Colorectal Cancer But Were Afraid to Ask. And before we start the talk itself, I would like to start by answering an age-old question, which, as you can see, was proposed way back in ancient times. These are two cavemen wondering why would anyone want to be a proctologist or the modern era colorectal surgeon. And the next slide shows that way back when I was in grammar school, even with a couple of my classmates, I'm discussing topics that are near and dear to my heart, such as colorectal surgery and the like. But truthfully, I find that being a colorectal surgeon allows me to have great impact on a personal level in patients' lives. And today we're going to talk about one of the very significant things that I and my colleagues deal with on a daily basis. So let's start by turning the clock back a bit. In the late 1990s, Katie Couric, who was a big TV personality, was married to a gentleman named Jay Monahan. Jay was going back and forth between New York and California, covering the O.J. Simpson civil trial. And he noticed that he was feeling very, very weak, and they just thought it was due to the travel. So eventually, he developed abdominal pain, was admitted to the hospital in New York City, and was unfortunately diagnosed with metastatic colorectal cancer, from which he succumbed very rapidly. And Katie Couric took it upon herself to try to raise awareness of colorectal cancer. She actually had a colonoscopy tactfully done on TV to try to show people that it was safe and not painful. So just trying to give examples of how far-reaching this problem is, former President Ronald Reagan never knew he had anything wrong with his intestinal tract until he had a screening colonoscopy. He was found to have polyps, one of which was malignant, requiring a colon resection. Audrey Hepburn, Our Fair Lady, regretfully succumbed to metastatic colorectal cancer. Darryl Strawberry, the famous baseball player, had many different issues, and one of the battles he did win was the battle with colorectal cancer. So he is a survivor. Tip O'Neill, the former Speaker of the House, lived for 7 years after a diagnosis of colorectal cancer. Charles Schulz, the artist from Peanuts cartoons, had many, many family members who had colorectal cancer and just, for some reason, refused to get screened and have a colonoscopy. By the time he succumbed and actually decided to have, or acquiesced, and decided to have a colonoscopy, regretfully, he was found to have metastatic colorectal cancer. So let's start by reviewing the gastrointestinal tract, which is a pipe-like organ system beginning here at the mouth and runs through a bunch of specialized organs and ends down here at the anorectal area. The area that we're going to be focusing on is called the colon, large intestine, or large bowel. Those terms are interchangeable. It's about a 4 or 5 feet in length organ, shaped like a saccular pipe, and the job that it performs in our body is to change a high volume of liquid stool to a low volume of solid stool as the waste traverses this organ. The last 6 inches of this intestinal tract is called the rectum, which is simply a storage organ for the waste made by the body, and then that eventually exits. The connection is encircled by a round muscle, which three-dimensionally looks like a bagel or a donut. We call that the sphincter, and that allows us to control bowel movements. The lining of the colon looks like the pink glistening lining inside one's mouth. So what is colorectal cancer? It's the abnormal growth of the cells that line this intestinal tract, specifically the colon. So a cancer in the colon is known as a colon cancer. A cancer that develops in the rectum is a rectal cancer. So it's just different anatomic location. So when we look at these charts here, we can see in terms of estimated cancer cases or in the United States, colorectal cancer is very, very significant and very common. There are estimated to be approximately 105,000 new cases in 2021 of colon cancer and about 45,000 new cases of rectal cancer. the risk is rather significant. It's a risk of about 1 in 23 for men and 1 in 25 for women. There's a very slightly higher risk amongst men, but it's really almost equally distributed between the sexes. In terms of cancer deaths, colorectal cancer death is between the second and third most common cancer death in the United States. Lung is number 1, prostate number 2 in men, and breast number 2 in women, followed by colorectal cancer. So it's very, very significant. And it's expected to cause approximately 53,000 new cancer deaths in 2021. There are over 1.5 million colorectal cancer survivors in the United States. The key, like any other problem, is detecting it early. When colorectal cancer is detected early, there's over a 90% survival rate. And 40% of colorectal cancers at diagnosis are found in an early stage, if people are going to be screened earlier. If you look at these world maps, the red areas indicate hot spots for colorectal cancer. We see that in Europe, Australia, and the United States. And this activity is similar in this chart for males and superimposable for females. So who does get colorectal cancer? As I said earlier, it's a fallacy to think that this is a male-predominant disease. The incidence is almost equal amongst the sexes. We do see that there is an increased incidence of colorectal cancer over the age of 50, though we are seeing an alarming trend of many, many younger people developing colorectal cancer. We've had patients in their even 20s, 30s, and 40s nowadays, and we think this may or may not have something to do with a change in the flora or the genetic biome, the bacteria living in the colon nowadays. We also see that no ethnic group is spared. This affects non-Hispanic whites, African Americans, and Hispanics. So it spans all different ethnicities. So what are some of the risk factors? We believe that it's got something to do with diet and geography. We know that excessive cigarette smoking and alcohol intake are negative factors. A family history is very significant, and we'll get into that. Some conditions known as inflammatory bowel diseases, such as Crohn's and ulcerative colitis, also result in increased incidence of colorectal cancer. The presence of polyps, which we're going to talk about, and obviously previously having had a colorectal cancer is a significant risk factor for the development of a second colorectal cancer. Inactivity is a risk factor. Obesity has been shown to be a problem, as is diabetes. So I alluded to something called a polyp. What are polyps? They are excrescences or growths that develop in the colon. They can be of different types when we look at them under the microscope. Some called hyperplastic, which have no risks whatsoever, and others called adenomatous, which are more problematic. And the interesting thing is that 90 to 95% of colorectal cancer was preceded or arose from what's known as an adenoma or a polyp. And there is thought to be something called an adenoma-carcinoma sequence, where you have normal lining of the colon, a polyp develops, the polyp tissue can become abnormal, and that eventually can turn into a cancerous growth. This has a lot to do with genetics and abnormalities in cells where we normally have certain genes that protect these cells from becoming abnormal. When one has a colorectal cancer, first there's proliferation of the lining of the colon leading to a polyp, and other problems with genes not protecting these cells result in the cells becoming abnormal, undergoing malignant change, leading to cancer. The vast majority of colorectal cancers are what we call sporadic. They just occur. We do see that about 10 to 30% seem to have some element of a family history linked to it, and there are a small percentage of colorectal cancers that actually are directly genetically linked. Again, this is a diagram of the colon. The various portions of the colon are named dependent upon the direction in which the waste matter is traversing that part of the colon. This area on the right is going up, so it's called the ascending colon. This is across, known as the transverse. Coming down, the descending. This is shaped like an S, known as the sigmoid. because sigma is S, and then the last area here is called the rectum. This diagram here shows the percentage of frequency of colorectal cancers developing in that particular portion of the colon. So we see that about 1 in 3 colorectal cancers develop on the right. The left side here is a hotbed of activity. So how do we stage colorectal cancer? Well, it's staged 1 through 4. 1 is the best and 4 is the worst. And an analogy that I use is the following. Imagine that the colon looks like a cardboard liner inside a paper towel or toilet paper roll. That would be a roll made of 1 layer of cardboard. The colonic wall is made of 4 layers, and colon cancers develop at the innermost one of those 4 layers. So if a cancer is found and it is confined to the inner layer, that defines stage 1, depicted in the diagram here. If the growth goes through all 4 layers of the wall, that would be called stage 2. The colon has blood vessels and lymph nodes that drain it. If microscopically tumor cells are found in those lymph nodes, this is under the microscope, that would define stage 3. And if the tumor cells break off, get into the bloodstream, they can then go to distant organs. All of the blood from the colon is filtered through a solid organ on the right side of our abdomen called the liver. So therefore, stage 4 or metastatic disease often is related to tumor cells breaking off and going to the liver or perhaps to the lung. This is a CAT scan revealing an unfortunate patient showing these multiple dark spots in the liver. That's very extensive metastatic disease in the liver, or stage 4. This is known as a PET scan, which tracks physiologic activity after a certain tracer is given, and these spots here indicate metastatic disease to the liver on a PET scan or a positron emission study. So what are some of the symptoms of colorectal cancer? Interestingly, early on, there are no symptoms whatsoever. So it can be a silent problem. We often talk about something called change in bowel habits. Not a pleasant discussion topic, but we normally function from our intestinal tract very regularly. When we start to notice change in timing, frequency, consistency of bowel movements, that can sometimes be a sign of a colorectal cancer developing. Sometimes one will overtly see blood in the stool, though not often. Unexplained anemia or a blood count being lowered on a blood test means the intestinal tract must be investigated, because that is the most common source of blood loss, would be from the intestinal tract. Later on, one might develop abdominal pain. Unexplained weight loss is also a late factor for finding, and weakness. Lastly, at the far advanced stages, one can present with vomiting, which is indicative of the intestinal tract being blocked, which means that one's colon cancer has grown very large and is obstructing the intestinal tract. So what are the benefits of screening? Screening leads to cancer prevention. When we remove precancerous polyps, that prevents one from getting cancer, because 90 to 95% of cancer is preceded by a polyp. This improves survival when we're screened, and obviously early detection markedly improves the chances of long-term survival. The analogy that I use when I'm talking to patients about screening is the following. The colon grows polyps analogous to one's lawn growing weeds. If you were to pull the dandelions out of your lawn in the spring before they go to seed, your lawn is not going to become overrun with dandelions. By the same token, if you're colonoscoped and polyps are removed, you will never develop a colorectal cancer. So that's the significance of screening. So what are the 5-year survival rates for colorectal cancer? This is from about 2015, and they kind of hold as a general outline. Stage 1, early stage, 90 to 95% survival. Stage 2, 70% survival. Stage 3 would be disease in the lymph nodes. The survival at 5 years drops down to about 30% there. However, if one receives additional therapy such as chemo, your survival is boosted back up to the survival rate of stage 2 patients, about 70%. And lastly, metastatic disease patients, somewhere between 5 to 15% 5-year survival rate. So what are the options for screening? Looking at the very last foot or foot and a half of the colon, called a flexible sigmoidoscopy, examining the entire colon with a scope, called colonoscopy. In the past, X-ray studies known as barium enema used to be done, but that's kind of fallen by the wayside. There's special programming that can be placed into the CAT scanner to look specifically for growths in the colon. That would be called a CT colonography. Other tests include testing the stool for hidden blood, or a newer, more accurate test of the stool looking for shed DNA in the waste matter. That's called a Cologuard test. The gold standard for screening still is colonoscopy, which is the use of a flexible fiber optic instrument to examine the lining of the colon when one is sedated. So it's a painless situation. So people often say, oh, I don't want to have a colonoscopy. I have to drink that horrible prep. Well, the way I look at it is drinking a prep and having a couple of hours of liquidy bowel movements can actually save your life. So to me, it's certainly well worth that playoff. Diagrammatically depicted, again, the colon is cleaned out the day before the procedure. You are brought into a very well-run unit known as an endoscopy unit, and you are sedated by a board-certified anesthesiologist, and then we, either as gastroenterologists or colorectal surgeons, route the colonoscope retrograde or backwards through the colon with the image from a video chip projected on a high-definition screen in the colonoscopy suite, allowing us to very carefully examine the lining of the colon. This would be a typical endoscopy suite, again, manned by nursing staff, the physician doing the procedure, and anesthesia staff. This is not general anesthesia, it's sedation, so you're breathing on your own, and it's extremely safe. This is an image inside of an individual's colon. On the left, this is the normal lining, pink and glistening. And on the right here, we see what is known as a polyp. This looks kind of like a mushroom with a head and a stalk, or might look like a clapper in a bell. So that's a polyp. We have instruments that we can pass through the colonoscope called snares that are introduced in a closed fashion. We can then open the snare and direct it over the polyp to snip it out. We run electrocautery through it. This would be a polyp, the snare being directed over the polyp, and then after the electrocautery is used, the polyp is removed, and it's withdrawn and sent to the laboratory for analysis. This, again, is a schematic of what we call a pedunculated polyp, a polyp that has a stalk and a head. Another type of polyp is called sessile. It looks like a coin or a small shell which does not have a stalk and lies flat on the bowel. These are sometimes more difficult to remove because they don't have a stalk. And this would be a larger growth, an actual colon cancer. So when we do this, often we become very adept at identifying lesions and problems. This would be, for historical interest, a barium enema revealing what was known as an apple core lesion. This actually represents a colon cancer where when dye was placed through the intestinal tract, there would be an absence of dye because there is a lesion filling that area. That's how they used to diagnose colon cancers. CT colonography, as I had alluded to earlier, is the use of a CAT scan with certain programming that allows more detailed view of the colon. A normal CAT scan of the abdomen is not a good test for diagnosing or finding intracolonic lesions. It would have to be a special scan called a CT colonography. Now, if an abnormality is noted on a CT colonography, then those patients need to have an optical colonoscopy anyway. On the left is a CT colonography image. The patient was then sent for an optical colonoscopy, and it confirmed the presence of the polyp, which then needed to be removed. So, as I had also spoken about earlier, there is stool testing that now exists. That would be a kit. The most common is called Cologuard, where a specimen is placed in a receptacle, sent to the laboratory, and it's testing for DNA that is shed by tumors into the stool. Much more accurate than the old-fashioned fecal occult blood tests. Still, if any of these tests are positive, then the patient is referred for an optical colonoscopy. And in this diagram, what we're showing is that a polyp or a tumor would shed DNA into the waste, and that is recorded and found on this test. There has been some work being done to try to develop a pill cam to examine the colon. We have this for the small bowel. They're still working for that, to develop that for examining the lining of the colon. So there are some genetic disorders that have a very high incidence of developing colorectal cancer, and they run in families because they are genetically passed on from generation to generation. The most common are known as FAP, or familial adenomatous polyposis, and another known as hereditary non-polyposis colorectal cancer. These result in often lining of the colon having thousands of polyps, as diagrammed here. These people have a 100% chance of developing colon cancer. They often develop at an earlier age. Those who are found to be positive for this gene, because it can be found on genetic testing, should be colonoscoped at very early ages. And if this carpeting of polyps develops, their entire colon and rectum have to be removed to prevent them from getting a colon cancer. This is an endoscopic photo showing many, many polyps in an individual with FAP. So what is the treatment for colorectal cancer? Well, mainly it is surgery. Now, the term surgery is certainly scary. Though I'm a surgeon, I don't want to have surgery. But in the modern era, it is so minimally invasive, it's really quite amazing. In the past, the standard approach when a colon cancer was diagnosed would be to make a sizable incision in the middle of the patient's abdomen and get above and below the part of the colon that bears the growth, take it out, and then put the ends together. So this would be the area removed for this patient if the growth were in the sigmoid colon. Then this is a diagrammatic depiction of that piece being taken out and the two normal ends being reconnected. Another area here, if the patient had a cancer in the transverse colon, we get above and below that abnormal area, take it out, and place the two ends back together. Nowadays, the vast majority of colorectal cancer surgery is performed in a minimally invasive fashion known as laparoscopic assisted colorectal surgery. Basically, again, one requires a bowel prep, general anesthesia. In the OR, a certain device called a trocar is placed in the belly button or umbilicus. Carbon dioxide is pumped into the abdomen, lifting the abdominal wall away from the underlying intestinal tract. Other trocars are placed, which are 5 millimeters, and they allow us to free up the bowel from its natural attachments in the abdomen. We then make a much smaller incision to extracorporealize or take the colon and growth out, put the ends back together, and put it back inside. We put numbing medicine in the wound. Patient is given a spinal injection preoperatively, and they have almost minimal to no pain. It's really revolutionary. 70% of the patients are discharged home now within 2 to 3 days with a protocol that we have called ERP, or Enhanced Recovery Plan. So again, this would diagram various trocar locations, carbon dioxide lifting the abdominal wall off of the underlying intestinal tract, and then extracorporealizing or removing the specimen through a much smaller incision. You may or may not have heard of what's known as robotic colorectal cancer surgery. Also, another option, it is a tool that some find helpful to get better exposure deep in the pelvis for low rectal cancers. But again, it's simply a tool, and it's surgeon's preference as to how they feel they can best get these growths out of the patient. It's another minimally invasive option. If one has a colon cancer that is removed, it's sent to the laboratory, and then it is staged. Stage 1 and 2 patients have such excellent survival that they do not even require additional surgery or treatment. However, if one is found to have a stage 3 or perhaps a stage 4 tumor, additional therapy in the form generally of chemotherapy is given to that patient to help their survival. The addition of chemotherapy for a stage 3 patient who has a survival of about 30% raises their 5-year survival up to about 70%, or similar to a stage 2 patient, just by giving them the chemo, which is orchestrated in a team approach with medical oncologists. So we work collaboratively with medical oncologists. Now, the last thing we're going to talk about is rectal cancer, which is a little bit more tricky in that it is cancer that can sometimes confuse one because there's so many different things to talk about. However, the rectum, as I said, is the last 6 inches of the large intestine. It is divided into thirds: lower third, middle third, upper third, dependent upon distances from the outside world. The lower third is 0 to 5 centimeters, middle third 5 to 10 centimeters, upper third is 10 to 15 centimeters. That's from the outside world. If one has a cancer in this area, we further stage it with something called an MRI. We scan the chest, the abdomen, and the pelvis, and we determine how locally advanced the tumor is. That will determine if a person has a locally advanced tumor, they might be given radiation and chemo up front to downsize the tumor, and then if tumor remains after that treatment, they are then sent for surgery. The surgery that is performed is dependent upon exactly how low that tumor is in the rectum. If it's in the upper rectum and it's removed surgically, we call that an anterior resection because we are removing the tumor and some of the rectum from the front. If the tumor is lower and we take that out, that's called a low anterior resection, diagrammatically depicted here, bringing normal colon above down to the normal rectum below after the rectal cancer has been removed. And we do this connection by actually using a titanium staple device. That's how the connection is made. We don't sew the bowel ends together. These are non-reactive staples, and they don't prevent any problems or present any problems for you. This would be looking inside after such a connection was made, where you see 2 ends of pipe being joined. Sometimes if a tumor is small and very low, we can actually just take it out through the anus without the need for an abdominal incision. Some unfortunate patients who have a tumor that is very, very low, right above the anal sphincter muscle, cannot be put back together, and those are the very unfortunate folks that require something called a colostomy. Nowadays, that is very, very rare because of the surgical instruments we have, the use of radiation and chemotherapy up front to downsize tumors. That has allowed us to perform a lot more sphincter-saving procedures, as we call them. And this would be what a colostomy is. It's sewing the end of the colon to the abdominal wall, since the anus and rectum have been removed due to the tumor's location, and that would be how the patient's waste matter would exit the body. Again, this is very, very rarely done in the modern era. Sometimes we have some more advanced techniques called transanal microscopic surgery to take smaller tumors out, again from below, sparing one an abdominal incision. Chemo and radiotherapy up front is used to downsize the tumor and hopefully allow some patients to be put back together who otherwise would not be able to have had that happen if they were not given the radiation and chemo up front. So the current recommendations for prevention of colorectal cancer include colonoscopy. That is the gold standard. And it is a fallacy to think that this is some horrific, uncomfortable procedure. You are sedated, you close your eyes and open them, and the procedure is over. You never really even knew anything was done. It is important to get screened regularly, adopt a low-risk lifestyle, physically active, don't overeat, don't smoke, don't drink excessively. You got to maintain an ideal body weight. That helps with all types of disease prevention. So that's kind of what I wanted to talk about today, a soup to nuts discussion about colorectal cancer. The take-home message is this. It is a common entity. It is the second or third most common cause of cancer death in the United States. It's equally distributed between men and women, but it is almost totally preventable by getting screened and having a colonoscopy, and if polyps are removed, you'll be in good shape. I thank you very much for your attention, and stay well. Thank you.